And then I'm going to introduce Jeannie Skinner. She's our Vice President, and she's going to introduce our speaker for this evening.
Hello and welcome to all. I see a lot of faces that are familiar and some new faces. That's really exciting. We encourage everybody to attend and spread the word with your colleagues. I have the pleasure of introducing tonight's speaker, Ms. Cathy Cabazon. She graduated with honors from Palm Beach Community College, associate's degree in dental hygiene, and a bachelor's of applied science in dental hygiene from St. Pete College. Her extensive background in the profession of dental hygiene includes clinical hygiene in general and periodontal practices, community health programs development, grant writing, clinical education, and education consultant for Aura Pharma, Inc. and dental product shoppers. Her passion for oral health and her desire to serve her community through early prevention and education has brought her to work with many national, state, and county leaders. In 2009, she sat on the Florida Department of Health, Florida Oral Health Workforce Work Group, moving forward access to care initiatives in the state of Florida. Catherine was appointed by Governor Rick Scott to the Florida Board of Dentistry in 2012, where she served as vice chair and the very first dental hygienist to serve as the chair. That's
a big page.
She is the chair to the Council on Dental Hygiene and serves the steering committee to the Commission on Dental Competency Assessment, the CDCA, as well as the Dental Hygiene Exam Committee for the American Board of Dental Examiners. She's also, she also is, of course, a member of the Florida Dental Hygienists Association and has sat on the board as well. Please welcome tonight's speaker.
Thank you. Thank you so much. I've got to say, I lecture since 2005. I've nationally, I've done RDH under one roof. I lecture constantly, and there's nothing that gives me more pleasure than lecturing to you guys. Honestly, so I'm humbled and I'm honored to be here with you. And one of my instructors, Ms. Hazel Kerr, when I was in school, picked me up today, so it was so awesome to be here with you guys. Yes, so I'm just going to add one or two things. As far as the dental therapy goes, if anybody's interested in any information on that, I could provide you some new changes or updates on that as well. And to let you know that there are 55 organizations in the state of Florida that are in support of this. There are over 35 dentists that I already can call on that are in support of this, that are speaking to their legislators. And there's only one organization that's against it. So, but the organization that is against it is a very powerful organization in Tallahassee. They're very powerful. And sometimes power is important. You know, people listen to it. So packing and having that dollars for helping our legislators, it is part of the process. You hate to think it is, but it is part of that process. So I believe the Florida Dental Association has at least, if I'm not mistaken, maybe $450,000 every year that they pack.
Wow.
We have 5,000 every year. So if you can rustle up a dollar or two, every dollar helps. So, and as far as for dental hygiene, this is also a career pathway for hygienists. A lot of us, I know me, and I'm getting a little older, to go to dental school, $400,000 in debt, I probably can't do that. I can't take off that time from my family and working. But dental therapy, for us, it would be 16 months. Because we already are licensed as a dental hygienist. So the dental therapist would do 80 procedures that a dentist can do, which includes at least 40 to 50 of your procedures. So it could be a pathway to a different career for a lot of us who want to expand and do different things. We just had a dental therapist that came down and did a big meeting in Miami, and she's from Minnesota. And she does, most of her day is fillings. That's what she does, children fillings all day long. She fills in for the pediatric dentist if they go on maternity leave. She rarely does hygiene. She's not dual licensed, so she really can't, but she wouldn't even be asked to do that because there's hygienist. So it's just like in medicine. The PAs didn't take the nurses' jobs away. The nurse practitioners didn't take the nurses' jobs away. And they became part of the medical team that now treats. And a lot of us see our own PAs and nurse practitioners. As a matter of fact, I like that. Unless it's a complicated case, then you would see your physician. So it's pretty much the same model based on. So if you have any questions, I can help you with that. But Today, I am here to talk about the wonderful Florida Board of Dentistry that I am extremely honored to sit on. I don't know why, but I always loved laws and rules. Must have been something wrong with me, but I always loved it. Even when I was in hygiene school, I was just attracted to it. I thought it was fascinating. And when I would go into private practice and I would realize how many people didn't know them, to include my supervisors, I found that challenging. It really upset me. So I figured, I wanted to sit on the board. Back in 2009, I was very lucky to have sat on a task force for the Surgeon General at the time, the Florida Surgeon General, where I was very fortunate to be at a table to do some work, like how you do those work tables and think about what can you do for workforce, what can we do for access in the state of Florida. So I was very, very lucky to sat at the table with the president of FDA and a Board of Dentistry representative. So I wasn't there for FDHA, I was there for a nonprofit 50C13, I can't even think of it right now. I worked for them because I ran a coalition for access to care in Palm Beach County. So I was there as a proxy for the director of that think tank that I worked for. I knew nothing. Trust me, I knew nothing. I just knew that people needed care. So I was lucky to sit at that table. Dr. Thaddeus Morgan was there, representing the Board of Dentistry, and Dr. Chuck Hoffman was there. And it was our job, we were tasked by the Surgeon General to figure out how we could increase workforce in public health arenas and how we could change access to care. So I'll never forget, Dr. Hoffman turns to me and says, well, do you guys want to do sealants? And I'm like, what are you talking about? We do sealants. He goes, no, unsupervised. Do you want to do sealants unsupervised? Do you want to do prophies unsupervised? And I said, Dr. Hoffman, it's not what I want to do. It's what's right for the people of Florida. So it has nothing to do with Cathy Cabazon. I'm just here as a person helping to develop change. And then Dr. Morgan said, well, I'm here as the Board of Dentistry, so my job is to protect the public, because each of us wear our hats, and we have to be able to take our hats off when we are in different arenas. So I just turned to Dr. Morgan and I said, your job is to protect the public. That's fabulous. Who's protecting the people that get nothing? And so he said, oh my gosh, I don't think I ever thought of it that way. So out of that workforce came the direct access that allows dental hygienists to work in health access settings unsupervised. And I credit Dr. Morgan, I credit Dr. Hoffman, So after that, Dr. Morgan called me up one day and he goes, do you want to sit on the Board of Dentistry? And I'm like, well, yeah, I'd like that. I never say no to anything. I'm like, yeah, I'd like that. So took some time, but here I am. So it is really a very fascinating process that I knew nothing about. I thought I knew nothing. And I'm very, very blessed that I have a great team. We have a fabulous board attorney, David Flynn. He's unbelievable. And we have great administrative staff. So I'm going to kind of go through it. This is the website, and I just wanted to share this with you because a lot of people, I will constantly get calls or texts. Cathy, where do I find this? Cathy, where do I find, because people know I'm a resource. So when you go on here, if you want to apply for licensing, you just click on licensing. If you want to renew, you just click on renewals. Let me see if this works. And that would be a no. So if you want to go and look up resources, that's where you're going to find your laws and rules. So you drop down the resource page and it'll share with you 466, 64B5, and then it'll actually have a place where you can download a PDF of the laws and the rules together. And everything's in there. And I just heard tonight that it's 100% updated. And then it shows meetings and then, of course, board members. So, and then down here, again, it has that, but you see where it says complaints down there? That's where, if there's an issue that you feel is not appropriate, you can complain as a licensed professional. Actually, it's in your statute that if you see substandard care or anyone breaking the Practice Act, it is your obligation as a licensed professional to report them. You can do it anonymously, though. That's always a good thing, too. And then down right here by lookup, if you ever want to look somebody up, you can. It'll tell you all their violations, everything. You just look them up. Before you apply for your next job, look them up. So, just saying. So that's what it is. So our structure basically is we are the executive branch of the Department of Health, okay? We are led by the Florida Surgeon General. The Florida Surgeon General is basically not the boss, but we are underneath the Surgeon General. We're appointed by the governor but we are confirmed by the Senate. So when you're appointed by the governor, that doesn't mean you're in. It still has to go to the Senate floor, and they have to confirm that. If it's not confirmed, then your appointment might be null and void, okay? We're each on for 4-year terms, and this gets a little bit tricky. So when I was appointed in May of 2012. So I thought I was appointed for 4 years. I'm like, oh, I'm good. But then on my announcement, it said until October of 2012. I'm like, how did I filled a vacancy. So you can fill vacancies. So there was a hygienist who had pulled from the board, and there was a vacancy left, so I filled the rest of her vacancy, which meant in October I had to reapply. So, and then I was on for 4 years because that was a full term. So every time you are done with your term, if you want to stay on, you have to reapply. You may only be on the Board of Dentistry for 10 years total. That's a law. So I have 7, next year is 8, but I'm up for reappointment in 2020, which means I could only satisfy 2 years. The governor rarely ever appoints, like right there when somebody's due. So it could mean that I could stay on for another year or two till they reappoint somebody, but I couldn't exceed 10 years. There's 11 of us on there. There's 7 dentists, 2 hygienists, and 2 consumers. Right now we're down a dentist and we're down a consumer. Okay, so there's only 9 of us, if I do my math right. There's only 9. So, all right, so what are we responsible for? Our primary responsibility is actually just licensure. That's what we're regulated for. A lot of people call them licensing boards. They don't even call them boards of dentistry. They call them licensing boards. So that's our primary obligation, is that. And then we have to do what we call rule development. So when a legislator passes a law, we have to apply rules to structure that law so people know how to navigate through that law. We assure compliance, which I'm going to tell you, it's kind of hard because the staffing and the dollars that the department or medical quality assurance has is limited. So they can't send people out to check on your offices. But they do a lot of compliance through people who have sedation certified. That's huge. That's mandated compliance. They have to go through. They have to be audited and stuff like that because, again, patient safety. We also impose discipline, and we review variances and licensures and things like that. So, and our main duty is, I am a member of the Florida Dental Hygienist Association. When I sit in that room, I am not a member of the Florida Dental Hygienist Association. My job is to protect the public. That's my only job. My job is also to make sure that we're moving rules forward to help with the advancement of dentistry. So that's a good thing that the governor has actually given us that right to say, you need to look at your rules. If they're antiquated, you need to fix them. If there's something that can be done, you need to change it, as long as you protect the public when you do change it. So I'll get into that in a little bit. There are also councils. There's a council on dental hygiene. There's difference between councils and committees. Council on dental hygiene and council on dental assisting are law councils. They were developed by the legislators. So they have to happen. And they are people that are appointed. The reason I'm the chair to that council is because that time that I sat on the board, that October that I reapplied, the other hygienist was off and I was the only one left. So I became the chair to the council. I thought I was going to vomit, but I did become the chair to the council. And then I just have been chair to the council ever since. Then there's a council on dental assisting. The council on dental hygiene, the reason that happened was way back many years ago, and I don't know the time frame, was that the Florida Dental Hygienist Association was looking to become an independent board. It didn't happen. So this was the concession. So what that means is anything that has to do with dental hygiene, whether it be a fee, whether it be a rule, whether it be a delegable task, or anything that has the word dental hygiene in it, the council has to listen to it first. And the council will make the recommendations and then bring it forward to the full board for their vote, okay? Council on dental assisting develops similar, but it's not mandated that anything having to do with dental assisting goes through the council on dental assisting. They didn't mimic exactly the law that the Council on Dental Hygiene has. Then you have committees. Now these committees here are all appointed by board chairs. The council, if say I'm due to, my chair ends in 2021 for the Council on Dental Hygiene, If I'm still there, whoever is board chair may reappoint another person. They could appoint me again, or they could reappoint another person, but they can't touch it for 4 years. So I'm in for 4 years, no matter what. Committees, we have probable cause, that's PCP. We call it probable cause panel. Rules committee, we have anesthesia committee, we have CDCA, ADEX, and finance committees. Those are committees that we have standing committees. The board chair has the right to develop another committee if they want to, and then they have a right to dissolve a committee. So probable cause, what they do is they look at all of violations and complaints and identify if they feel there's probable cause. And I'll get to that in a second when I go through the process of complaints. Rules committee would look and develop rules. Now, if it had a rule to do with hygiene, the rules committee can't touch that. It's got to go to the Council on Dental Hygiene. So anesthesia, what they do is they do everything for anesthesia. Our anesthesia law is also in that rule, which is Chapter 14. They do sedation, pediatric conscious sedation, oral sedation, nitrous oxide, anything having to do with that goes into rules. Goes into the anesthesia committee, and there's a chair to that. Now CDCA, because CDCA, formerly known as NERB, so not to confuse this too much, is actually the administrative body that puts on the exam in this state. So if whatever college has the exam, CDCA brings their team in, and they're the ones who get the examiners, they get the admins, they get all the equipment, they get everything, and they're the ones who administer the test. They house the results and do all that. They also administer the laws and rules test in our state now. The Board of Dentistry doesn't do it anymore, or the Department of Health doesn't do it anymore. Because CDCA now administers our test, and our main priority is licensure, there has to be a dentist that sits on the steering committee for CDCA, and there has to be a dental hygienist that sits on the steering committee, because we want to know what they're doing, because they work for us now. So every state that has CDCA do the administrating of the test, they have to have a representative of a dentist and a hygienist on there. ADEX is actually the test that they take. So it's a separate entity. CDCA administers it. ADEX is the test. So we also have to sit on the ADEX committee. So there has to be a dentist that sits on the dental exam section, and then there's a hygienist that has to sit on the hygiene section. They're
same as CDCA and ADEX, the same hygienist and the same dentist?
Sometimes it is and sometimes it isn't, but it's good if it is the same, because then they understand the processes of both. It has been the same for the past few years.
And it's a board member that sits on?
It has to be a board member, present active board member. Okay, so I've sat on CDCA and ADEX probably. Irene Stavros was before me, and once her time was done, I was the one who took it from there. So we actually go in a room with all the other states that accept ADEX, and we write that exam. We look at it to see if it's valid, do we want any changes, and I will tell you there's some changes down the pike this year. Very minimal, but there are some changes. So, and then there's a finance committee, which I want nothing to do with that, so. Yeah, because I don't know if you know, but hygiene money is separate from the dental money. And what I mean by that is how the board functions is based on your licensure applications. All the money you put in for licensure and relicensure, that money goes to the Board of Dentistry to function. So what it means is when they brought me up here today, the money that you put into that pool will pay me to come up here. It pays for the attorney, it pays for the administrative team, and hygiene is separate from dentistry. It also would pay if there's any type of a complaint or a violation on a dental hygienist. It would come out of the hygiene section of the money. The good news is we always have tons of it because we usually don't have problems. So dentists are completely separate, so any type of thing that happens with a dentist and violations comes out of the dentist money. All right. Also, when if a dentist or anybody else who's licensed had to pay a fine, that would go into those pots too to kind of keep it going. Dental is in the red. They're in trouble. They don't have enough money.
They used to put it all together.
They used to, but FDHA wanted it separated many, many years ago. And the reason they did that is they wanted to prove if they could stand on their own that they could be sustainable. And we've obviously proved that we can be sustainable on that. This is way before my time. So, regulatory guidelines, let's see. We regulate dentists, dental hygienists that are licensed in Florida only. If somebody practices dentistry or dental hygiene and does not have a license in this state, we cannot regulate them. They would go to unlicensed activity regulation. We don't regulate. So if you're not licensed in this state and we find out you're doing hygiene, how dare you? Bam. You would never come in front of the Board of Dentistry because we only regulate Florida licensed. You would go to what they call the unlicensed activity unit.
50 years of it.
50 years. And then we also regulate certified dental radiographers, and I'm going to get into that because that's really strange and tricky. And then dental laboratories. We have a regulatory system on them too. We do not regulate any out-of-state dentist. We do not regulate expanded functions dental assistants. There's 2 pathways to radiology in this state. You take the radiology course and register at the state of Florida and pay them $35, only one time in your life. And then you're considered RD, registered dental radiographer. Or you could take a weekend wonder expanded function course in radiology and you still can do the same thing as the other one can that registers and pays, but you're not regulated. I don't know how that happened, but it did. Not everything, and this is why sometimes looking back at the rules are saying, those 2 rules are in conflict with each other, or there's 2 pathways. So for example, if a dental radiographer did something that had to have her certification, they call certifications licensure too, had to have that revoked, it wouldn't matter, they can go right next door and work because it could just be expanded functions. So it really doesn't matter. So this is where laws and rules become challenging, and there's a lot of layers into it.
How many CDRs are there in Florida?
How many registered dental radiographers are in Florida? I don't know that number, but right now it's less and less and less because people know there's another pathway.
Okay.
So all the CDAs are. Those who graduated from the programs and got certified and took the DNB, they all are. But the people who just got on the job trained and took a little course on the weekend, they're probably not. Because there's a lot of confusion with that amongst the professionals. I mean, I didn't even know that. I thought everybody had to register as a radiographer. I found out they don't. So, and I still have a little issue with it, but it's okay. We don't like everything in life, but we can't always change everything. And then we do not regulate unlicensed activity like I shared with you, okay? So an example of unlicensed activity is a lot of people when they were doing whitening in Sam's Club. The South Florida Fair, they were lined up around the corner to pay $99 to put a tray in their mouth. I'll never forget one day I was at Sam's and I was so irate about it, I wasn't on the board. And I was going up and I wanted to find out what their percentage of whatever, and I'm irate and I'm going up, forgive me, I've been working 90 hours for the past 2 months. And my husband goes like this, dental police, dental police. I'm like, stop that. So they did not know what their percentage of bleaching solution was. So, but we could not, what?
These aren't regulated at all?
Can't regulate them. They're not licensed in the state of Florida. We can't regulate them.
So there's no office, there's no umbrella, there's no watchdog for unlicensed.
There is a watchdog for unlicensed activity. It's not identified in the State Practice Act that it's a procedure of dentistry. We have no right touching it because that's federal trade. See? So those are those gray areas that you got to be careful about. We all believe it's dentistry, but it was never outlined in the scope of dentistry for Florida. So can't touch them. That's why South Carolina got sued, or North Carolina. I can't remember which one of the Carolinas. One of the Carolina boards got sued because they did that. They were irate and upset, just like all of us were, but they went after them. And the Federal Trade Commission said, how dare you go after something that's not considered your trade? They slapped them with a lawsuit.
Example, Botox or something.
Botox, that got passed by the board, but it is not considered part of dentistry, but it is considered part of craniofacial. Mm-hmm. So there's always gray areas. There's always these little areas that you can kind of work around. So that's why we have to be very careful on the board level not to over-encroach our obligations and our rights, because if I vote no all the way down the line, I will still be sued.
I have a question.
Yes?
So dental whitening is not under dental?
It's not described as part of the scope of dentistry. There's a definition of dentistry, and it's not in the definition of dentistry.
Why wouldn't they put it in?
I don't know. They just never did. But now I don't think anybody cares, because guess what happened? Everybody's doing cosmetics. So it really blew up the world of cosmetics for dentists. It actually it improved it for them.
Is that the same with the smell and Invisalign stuff? I mean, it's not
It might be.
Invisalign, but the
It might be.
advertising just
Smile direct.
It might be, and we're basically not allowed to talk about it. Because if a dentist works for them and does something wrong, then they come in front of the board. But we can't go after somebody if they're not. So it's, again, a touchy area. And I'm going to be honest, I'm not willing to be sued over that right now. So we've been told, you've got to stop. Do not move forward with any activities on that. Wait to see how it unfolds and what happens, because I could lose everything on that, you know? So, and I don't know their structure. We don't know their structure. So, yes.
Just a question then. So if they aren't regulated or
They're not regulated by the Board of Dentistry.
so if the patient, because the Board of Dentistry's objective is to protect the public.
For licensed activities.
That's where it keeps on getting tricky.
That's where it is tricky. Our job is to protect the public for licensed dental professionals. So we make sure that the licensed dental professionals do not harm the public. We do not worry about if somebody put bleaching in Sam's Club or this or that, because that's not part of what we do.
So if a consumer has a problem, say with one of those unlicensed.
The kiosks, yeah.
Yes.
Then they would have to go and sue.
Then they would have to go.
They would have to go and sue them. Correct.
I gotcha.
And then if there was a dentist who was part of it that created the problem and is licensed in Florida, then they would come in front of us. That's how it works. But if they were licensed in California, they would go in front of California's board. It's layered. Laws are layered. It's not just what you think it should be. It really is very layered. So are we good with this? Yes.
Okay, so South Florida is super popular for dentists that maybe
I'm from there.
in another country, and they're not.
The international dentist.
And they are internationally providing dentistry, but
They're not allowed to be doing that.
Right, so they are impersonating I don't know, whatever.
Whatever.
And like,
They're practicing dentistry.
without a license.
Right.
So-
But they're licensed as a dental hygienist, so they would go in front of us.
But let's say they're not.
Then they would go in front of unlicensed activity unit.
Okay.
So there is a unit housed in the department that protects the public for people who are practicing without licenses. But that's not what we do as a Board of Dentistry.
Okay.
They go in front of unlicensed activity.
Okay.
And we'll hear about the reports like at our annual conferences we'll have and stuff like that up at the department. We'll be like, oh my God, there was that many people did unlicensed dentist activity. But now if a dental hygienist who is licensed, was licensed as hygiene and doing dentistry together, they would go in front of unlicensed, and then they would come in front of us and have their license of dental hygiene maybe revoked. Okay, because then we can regulate them because they do have a license. So again, I know it's kind of confusing. Yes?
So let's see if I can say this right. So if there are certain activities that you're saying that aren't lying under the scope of the practice of dentistry, who makes
The definition.
the definition? Who makes the decision to move those things into those categories?
That would be legislators.
I see.
Right. So if somebody wants to open the law and add certain things to the law, like we wanted to add local anesthesia, right? It wasn't part of our scope. It was a law change. You have to have somebody sponsor a bill, and then you've got to lobby it like the dental therapist is. You've got to make sure everybody knows and understands it, and then pass it. So that's how that works. So, and I'll get to laws and rules and where they are and what in 2 seconds, okay? All right, this one blows my brains, but this is kind of how the process goes. It gets much layered, and I'm not going to go there, but basically somebody puts in a complaint. They complain to the department receives it, does an analysis. Either they issue a citation, the person can dispute it, then it comes back to there, then it goes over for, if it's not disputed, then it goes into the final order, and then eventually it ends up coming into probable cause panel. Because, okay, so I'm going to just break it down nice and easy. Say somebody calls and complains, oh, the doctor put on a bad crown, blah, 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 blah. Goes into the department. The department does the analysis on it, calls the office up. First talks to the patient, then talks to the team members, gathers all of the records. And the records that are gathered are actually the records from the minute that patient walked into that office to the minute that patient filed that complaint. So when we see it, I see everything. I don't just see that part about the crown. I see their perio charts or their lack of perio charts. I see radiographs or lack of radiographs. I see radiographs with radiographic calculus on it and crowns placed on it. So we see a lot of things. We see whether a medical history was taken, whether they're updated. We see everything. Every single thing. Every signature of the dental assistant that touched that person, the hygienist, everything. So then the prosecution team, they gather all that information and they say, you know, by the statute and the definitions of what we have, that dentist did probably practice below substandard of care. They didn't take a post-PA of that crown. They left cement, open margin, whatever. They look at that and analyze that to see if the dentist did do something that was below the standard of care. And then it ends up going into probable cause panel, which is a panel of, has to be one board member, one dentist board member, and then it can be past board members sit on that panel. And then they have a meeting and they identify if they believe there's probable cause. Because you got to remember, the investigative team are not dentists or dental hygienist. So they do the best with the Practice Act, but that doesn't mean they know everything. So there's been cases such as the example. Patient had said, that dental hygienist did something she wasn't supposed to do. She wasn't allowed to do that. So every record comes in, blah, 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 blah. The prosecution team kind of knows, but they really don't know that much. So it goes to probable cause, and we look at it and go, she was well in her scope of practice. She was fine. So we dismiss it at probable cause. But if we believe that whoever it was practiced to the below the standard of care and caused some harm, or even if there wasn't harm, if they practiced below the standard of care, then we impose a violation. Then it goes in front of then it goes back to the dentist or the dental hygienist or the radiographer. They either can accept it or they can dispute it, but they have to come in front of the board. So a settlement agreement is then put together by the department, and that's when they come in front of the board. So that's what's going to go on tomorrow. So whoever goes in front, then they plead their case, and there's some times in situations that just because we had information, there's other situations that you say, you know what, they've never had a violation before. Things happen. My gosh, we're human. It wasn't with malintent. They've restructured their whole practice, changed everything. Linda, how many times have we said, are you doing risk management? Bring in a risk management team. Do this. Do something to fix and change your practice. Right? No. Oh, I'm sorry. It's the other Linda. I'm sorry. No. Yes. Oh, no. But so, you know, if they show, like say they show that they already contacted and brought in a risk management team to figure out their protocols and their systems weren't proper, and they bring that to us, we realize that they made a mistake, maybe they weren't aware, it was not with malintent, and they've already started the process to rectify it. So sometimes we will even dismiss the case at the board level. So we have a right to dismiss the cases, or we have a right to impose an even stronger violation than what probable cause does. So we have those abilities to do it. So it's like judge and jury. So the laws. The laws are in 466. Okay, that's what governs dentistry and dental labs. A law is developed by the legislators. They're the ones who put the law into place, not us. Legislators are the only people that can put the laws into place. It has to have a bill in the House, a bill in the Senate. They have to match each other. They can't be opposing bills. They have to have exactly similar language. They have to pass through 3 committees in each of the House and the Senate. Then they end up on the House floor, Senate floor, get voted on, and then hopefully signed by the governor or vetoed by the governor. And it's a process. It's a long process. Also, those committees that it passes through, like if it was for housing, it would go through the Housing and Developing Committees. For health, it goes through Children's Health and Family, Health Appropriations. You could have a chair of one of those committees goes, I don't like that bill, I don't want to hear it. And they have a right to do that, which is really sad. And it happens over and over. It's a lot of politics, more politics. It's actually created an enormous amount of angst for me because I thought people were supposed to do what was right. I really do believe that in life. I didn't think people do what's self-serving. So Chapter 456 is what governs all health professionals. So this is where you'll see your med errors is in there. You'll see your domestic violence is in there. You will see in there that your new human trafficking has been put in there. There will be other things in there such as I could not sit on the Board of Dentistry if my main source of income was from a teaching institution. That's not in my Practice Act of 466. It's in 456. The only one that can is medicine. They can have a board member that has 100% their income comes from education. Mine can't. So it's like, so we have to look in two places for some of our laws and our rules. Okay, so they're developed by the legislators, and the Board of Dentistry cannot change the laws. We cannot touch those laws. No matter how much we want to, we can't. And we must be enforced without any exceptions whatsoever. So if somebody breaks a rule, we have leeway to say, or you can put in a variance and say, you know, I have a hardship to this rule, so I'd like you to give me a variance today, or an exception to this rule. We have a right to do that, but we cannot ever do a variance or an exception to a law, because a law is a law. We can't change that. Also, a rule cannot be more restrictive than the law. And what I mean by that is, I'm going to give the perfect example of what happened the first year I was there. No, it's actually 2013. Local anesthesia passed in 2012. So rules were written to develop around the statute in that same year of 2012. Well, in 2013, there were some board members who felt that they wanted to kind of restrict or, change the rules a little bit and make it a little stricter. They wanted to regulate the amount of injections we would give as a dental hygienist. They didn't want us sticking people all day long, injecting them all day long. They wanted to make sure that, people weren't, and they believed in their heart they were doing it to protect the public. So they wanted to put in some language that said a dental hygienist cannot administer local anesthesia to another patient unless the previous patient has been dismissed by the dentist, because again, it's under direct supervision. So I remember saying to myself, well, what happens if that patient now goes to the dentist for restorative and my next patient that needs anesthesia, I can't do it. So I'm thinking to myself, why? It doesn't make any sense. You have a nurse that goes in a hospital and all they do is pick lines all day. What do you care? What do you care? It's not hurting anybody. Show me where it's hurt. So I had to, one of my massive tasks, that was my first big one, was put together the rationale why that would not be logical, why that should not be a rule that was passed. I didn't know a lot back then. If I knew what I knew now, I would never have done the work that I did that day or those few months. Additionally, there was in there that said that we could not we can't do local anesthesia on a sedated patient, right? But then there's what they call oral sedation with an anxiolytic, right? But how many people take anxiolytics for life function? So that means every person that comes in and discloses on their medical history, which is 80% of the population where I come from, I'm not going to be able to numb them, because now it said an anxiolytic. So I wanted clarity on that. And then I didn't believe nitrous oxide was a sedative. I didn't believe that it was sedation because it's an analgesic. So it went back, it had to go to the Council on Dental Hygiene. So we got an amendment stating that we could anesthetize a person that was taking nitrous oxide as long as the doctor turned the nitrous oxide on. We could anesthetize that person, and we could anesthetize a person who was taking an anxiolytic for life function, not prescribed for dental anxiety. So that's the difference, okay? So if your patient says, well, I just took a pill today because I'm so nervous today, doc gave me one and this and that, can't do it. But now if they say, I take them every day because that's how I function, then you can. The difference, I don't really know, but that's okay. It's the way it's written, because it's a law, we can't. Whether it makes sense or not, it's a law, so we can't. So what happened with the number of injections was, it was going, and I was like, it can't be going, and what's going on here? And all of a sudden, David Flynn, our board attorney, stood up and said, guys, you can't do this. There's no place in that law that says you can regulate the amount of injections. Your rules have to support this, not supersede it. So and they said the legislators were very, very explicit in how they wrote that. If that was a very broad law, maybe. But it said, XYZ, BD, and F. It had it all. You cannot regulate how many injections they give. You cannot do it. So they tried again, and board attorney goes, nope, no vote, you can't do it. It'll get kicked out. It will never even go through. So that is how superseding your rulemaking authority can happen. So you can't make a rule that's more restrictive than the law. So, and that was a good thing for us. So this is, if you ever want to pull them up, they go by chapters. So basically what we deal with for us is basically in 2.3, 2.3.5, 2.3.4. That's mostly about hygiene. But you can see everything is defined. It defines here what the Board of Dentistry is. It defines what the examination of a dentist is, application for health access licensure. I mean, it goes through pretty much and gives you the laws that focus completely on the practice of dentistry and dental hygiene and radiography. So, and good luck interpreting, because it's ambiguous. You know, it's so hard sometimes. It's all of the intent of the legislators and this and that and crazy. So our health access law, does everybody know what that is? That it passed in 2011? I think we were 2011 for health access, anesthesia 2012. It means that in a public health setting or in a health access setting, these are health access settings, county health department schools, school sealant programs, federally qualified health centers. If you don't know what those are, they're basically like your community health centers. They're not departments of health. Other health we can do unsupervised, we can do assessments, sealants, prophies, fluoride varnish. But to do a prophylaxis, we must have a medical clearance from a physician or a dentist to say that we can do that prophy, all right? Then also, in order to be able to do another, we would have to have an examination within 13 months. So this is a bit of a barrier to care, because a lot of these health access settings, if you're working at a county health department or you've got a sealant program or you're out on a bus, you don't know if that child had an exam. Because you can ask the mother, you don't have the affidavit, how do you document it? Where's the tracking system on this too? So it's a challenge, but it creates a barrier. And because we like to go by our laws and rules, we abide by it. But it does still create a little bit of a barrier for access to care. But we can't change that. Why? It's a law. Can't change it. So, but, and we cannot be direct billed. The health access setting is billed. All right, so that means if you work for a Head Start center and you go in and you do screenings and fluoride varnish applications and prophylaxis in a Head Start center because you got a medical clearance, or in a physician's office, they would be billed. They would bill and then they would pay you a paycheck. That's how it works. We can't have direct billing. So, and we have to have liability insurance for that. We must have liability insurance because we're basically practicing unsupervised. So as far as fluoride varnishes are concerned, you are allowed to place a fluoride varnish on every street corner if you choose to. You just can't charge for it. So we have no supervision level for fluoride varnish. My mom had radiation and chemo, and when I went to her chemo every week on Mondays, she had head and neck cancer. And there was like 7 people in there that had head and neck cancer, and they all went the same on Mondays. And some lady, she had trays, and she was like, I can't even get them in my mouth because it was ripped apart. Her whole mouth ripped apart. So I took my little fluoride varnish and my little gloves, and I went in and swiped everybody's mouth. And I was allowed to do that. I didn't charge. So we're allowed to do fluoride varnish anywhere. We're unsupervised completely, and it doesn't even house in this. We can do it there, but it also houses separately. Okay. Other settings of practice, public health programs and health access settings. Oh, okay, this is other places that we can practice. Upon a patient of record of a dentist who has issued a prescription for us, and that prescription is valid for 2 years, we can work in licensed public and private health facilities, other public institutions of the state, public and private educational institutes, and nursing homes and patients with non-ambulatory care. So we could actually, if our patient of record is now in a nursing home, our dentist patient of record is now in a nursing home, doc does an exam again, they can issue you a prescription for 2 years, which means you could cart yourself over there and do hygiene care for that person for 2 years. Which is a nice thing to be able to do because nursing homes are not in health access settings. Everybody thinks they are, but we are not allowed to go in a nursing home unsupervised unless they are of the Department of Health. If they're a nursing home that's housed under the Department of Health, then we can. But these private nursing homes, no, we're not allowed to go in there. We have to have a dentist authorize us to go in.
Quick question.
Yes.
The public health, is that something like Soul Sponsor Center?
Yes, like if they're 501c3, if they're a nonprofit, if they're federally qualified, if they're funded by a federally qualified health center, they're considered a health access setting. Juvenile justice, schools are health access settings. Dental hygiene programs are health access settings. So there's a lot of them that are, yes.
So how does sovereign immunity work with?
With that.
Yeah.
You basically would apply to the Department of Health for sovereign immunity. And sovereign immunity only works if you're volunteering. It doesn't work if you're getting paid. Yeah, so if you get sovereign immunity, you actually apply to the Department of Health in their dental program. They have a dental program, the Department of Health, at the state level. I don't know if any of you know who Dr. Zapert was. He was our dental director in this state. Unfortunately, he just passed away, and he was the most amazing person in the whole wide world, because he said before he leaves his position, there will be a dental hygienist in every single school. So I hope to carry that on, because he was an amazing person, and he died suddenly. But so sovereign immunity, like if you're going to do Mission of Mercy, you want to get sovereign immunity. I volunteer at Caridad, which is a free nonprofit health clinic by me. No pay, no money exchange, nothing. I get sovereign immunity for that. So you just apply to the Department of Health for that. Okay, so what are grounds for disciplinary action? Failing to practice to the standard of care. Now, everybody asks me, Cathy, where is it written of what documentation is? Where is it written if we have to do this and this and this and this? If we wrote every single standard of care in that book would be this big. So the standard of cares are developed by the organizations, the agencies. ADA for general dentistry, AAP for perio, right? ADH, well, we don't really develop any standards of care, so AAP develops hygiene standard of cares. The maxillofacial surgeons would do for surgeries, for implants, and all of that. So the organizations that licensure is housed under, they develop those standards of care. So like there's standards of care for implants, but it's not written in our rules or in our laws. So what it does say is you have to practice to your standard of cares of your organization and your licensure, but we don't laundry list them because we can't. So what happens is if there's a violation or if there's a problem or something like that, we would look up what the standard of care is. And we had a really great case not too long ago where, and our cases are backlogged sometimes 5-6 years, okay, because that's just how it goes with red tape and bureaucracy and investigations and, you know, put it off and they ask for extra time. So we had a case where standard of care for implants back in the day was not pano cone beam, it was a PA. And this doctor's in front of us now, and everybody's irate because, oh my gosh, they didn't know there's a PA. What are you kidding me? And blah, blah, blah. And then one of our board oral surgeons said, back in this year, that was the standard of care. You cannot impose a violation on that person from that time because that was the standard of care that was written back then. So you have to go by the standard of care of when the violation actually happened. Okay? So failing to report licensees who you know are not practicing to the standard of care or violating our laws and rules. It actually is your obligation to report. Illness or use of drugs, alcohol, or resort of mental or physical condition. Anything that would create harm to a patient and you know somebody's practicing that way, it is your obligation to report it. Failing to report to the board within 30 days of any violation of a guilty plea. So if you were caught stealing or anything else like that, you have to report that to the department. If you get pulled over for a DUI, you have to report that to the department. Even if it was on a long vacation in Cozumel, you have to report that. Okay, maybe if it was out of country, you might not have to, I don't know. Making deceptive, untrue, or fraudulent presentations in or related to the practice of dentistry. So if I said to somebody, oh, I'm Dr. Jones. I'm not touching him. I'm not working on him, but I'm Dr. Jones. I led them to believe I'm a dentist. That was fraudulent, right? That's a violation. Because I led that person to believe I was being fraudulent. Failing to keep written dental records and medical records justifying the course of treatment of the patient, including but not limited to the history, examination results, test results, x-rays if taken. So we had this amazing case. This lawyer was so smart. Technically, we say we have to write down all drugs, right? That's part of what's in our law. You have to write down drugs that you dispense. So this dentist didn't write down the local anesthetic. So he said, well, what's the definition of dispensing a drug? Dispense for a person to go home with. He said, that's part of the procedure. So it really isn't. I'm like, lawyers, they're good, aren't they? I'm like, But he still lost. So, but the reality is it's how you perceive and look at something. It's really, a lot of it is kind of tricky there. So, also delegating professional responsibilities to a person who is not, oh, there's my typo, I found my first one, not qualified by training, experience, or licensure to perform them. So that means sometimes when you've been asked to do things you're not supposed to do, that should be reported. I can't tell you how many times I've been told to turn nitrous oxide on. All day long. I went to a temp job one time and the dentist said, oh, your 9 o'clock patient is a nitrous patient. I said, okay, how would you like me to alert you to come in? He's like, what are you talking about? I go, well, I'm not allowed to turn that on. He said, well, that's absolutely ridiculous. He goes, I want you to turn it on. I said, no, I will not do that. He goes, fine, I'll have my dental assistant come and do it. So I should have reported that, but I didn't, because I didn't know I had to. And then failure to pay back your student loans. It is mandatory to have a license revoked or suspended until they start paying again. I did not know that until about a year or so ago. Yeah. So now rules are completely different. Rules are developed what? To support the law, right? So when a law about local anesthesia came into place, rules had to be developed. When a law about health access settings, rules had to be developed to support it, because they're a little bit more detailed that help to guide the person to what they can do and what they can't do. So that's in 64B5, that governs dentistry, and Chapter 64B27 governs dental labs, because they have rules and guidelines to the laboratories. So we develop those ourselves, and the rule can't be stricter than the law, and the Board of Dentistry can actually waive or change those at any given time. So we have that right to look at those. And actually, we are charged by that by the governor of this state, is to make sure that you look through your rules and make sure that they align with statute, because sometimes if you change a law and you don't change a rule, it's a problem. So you still have to change and make sure that it's all up to date and things like that. So that's why I was allowed to change so many things from supervision levels, because we have that right to change supervision levels. Okay? So this is where you find them. Again, everything is pretty much follows statute. It's the organization of the board and procedures, examinations, advertising, practice permits, prescriptions, ones that pertain to us. Anesthesia, I try to stay away from it because it's not in my area. Why would I dabble in something? I leave that to the people that are anesthesia certified, they're the experts. I try not to dabble in that too much. This is disciplinary action. So in Chapter 13, we have a huge outline of what violations we're allowed to impose and fines. So just because I think Dr. Jones should have his license revoked doesn't mean Dr. Jones does get his license revoked. So there's guidelines. And then this is ours, remediable tasks delegated to hygienists and dental assistants. The Board of Dentistry has the right to delegate remediable tasks that are reversible. They cannot delegate irreversible remedial tasks. So that's why you've seen so many years, throughout the years, we've had things added. I graduated, there was no whitening when I graduated. There wasn't. It wasn't in our delegable duty. Now it is. Okay? So the board has that right to add things to your delegable duties as long as it is reversible. And then here we go all the way down to the sterilization and disinfection procedures. Any questions on that? Yes?
A question came up not too long ago about whether a hygienist can perform the Zoom whitening without a dentist.
No, they can't. It's under the direct supervision of a dentist. All whitening, yeah, the whitening. With the light is under the direct supervision of a dentist. So, but I've got good news. Tomorrow, we're hoping it changes. So put it through tomorrow. So everybody remembers what direct means? Yes. Means the doctor must authorize the procedure, must be on the premises, and must then check afterwards. That doesn't mean sitting in their room doing their procedure. They must physically, even if they walk in and go, how are you feeling? Everything okay? Okay. That's good enough. They don't have to get in the mouth and go, where'd you stick? Oh my God, are they good? They just have to make sure the patient's okay before they leave, all right? So that's what direct supervision is. Indirect means authorized stay on the premises, but they don't have to check afterwards. General means authorized, they can go golfing. And then without means you're not supervised. So that's your fluoride varnishes, and you're not supervised if you work in a health access setting, right? Okay. So, delegable duties. Ours is 16006. It used to be in 16006 and 16007, and I merged them together because it was very confusing where to find them all. We may do everything a dental assistant can do. We must be CPR certified. We must do continuing education, and we are tracked and regulated by the Board of Dentistry. Dental assistants, it's chapter 16005. CDAs may do all things that are in the dental assisting scope of practice. On-the-job trains basically can do two things under direct supervision. That is it. Retract and suction. That's all they're allowed to do. So dental assistants that are in the office that are not CDAs and don't have an expanded function for impressions, they are not allowed to take them. And nobody knows that difference, do they? No. We all think a dental assistant's a dental assistant, and they're not. They're very different. Expanded function, dental assistants can only do what is on that expanded function certificate. So I don't know many expanded function courses that teach from soup to nuts what's in their delegable duties. So if they weren't taught how to do a periopack, they're not allowed to do it. If they weren't taught how to do a radiograph, they're not allowed to do it. If they weren't taught how to do an impression, can't do it, can't do it, can't do it, can't do it. But then again, no doctor ever looks at them. They're not posted anywhere, and they're supposed to be posted, just like our licensure is supposed to be posted. They do not need CPR. They only need CPR if they're working with a dentist who does nitrous oxide or sedation. Then they have to be CPR and have the same equivalent that we have to do. They don't need CEs unless they're Danby. Danby requires CVE if they want to renew their Danby. And only CDA and dental radiographers are tracked because they're registered as dental radiographers. So the other expanded functions can do whatever, get fired, and go down the street and work for Dr. Jones and do the same thing. And we know dental assistants do a lot of things, right? Mm-hmm. They do. They do a lot of stuff. So it's not something that makes me happy. There's a lot of states that are looking at licensing and certifying dental assistants, but it's not something our board has ever been wanting to look at. So again, can't fight City Hall. So dental assistants, let's go through a little bit more. They're not all trained the same, as I said. CDAs graduated from accredited programs. They're required to do CEs for Danby. They can do all duties. Expanded functions can only do the task that's identified. Only dental radiographers register with the state and can be disciplined, and the certification must be placed where it is. Under general supervision, this is the only thing that a dental assistant can do. Oral hygiene instruction, ed programs are fabricated temps in a lab only. There is a section for emergency patient, though. So if a patient has an emergency situation, we can, or the dental assistant can do one or two things, but the patient must see the dentist within, I can't remember if it's 48 hours, 72 hours, but it's in there. I don't know everything to memory, I apologize. But if you think about it, when docs aren't in the office, what are dental assistants doing?
Everything.
Tons of stuff. Tons of stuff.
And we can't delegate to take on extra.
No, we cannot delegate.
I always wondered why Florida doesn't recognize CDAs, why just because there would never be jobs.
I don't know why. I mean, I don't know the reason for it. I mean, I tried when we get to the expanded functions restorative auxiliary, I tried very hard to say that person needs to be regulated. They need, and the reason I like regulation is not because I'm an over-regulated kind of person or personality, but if you're doing something wrong, we need to remediate. And not because we want to spank or control. We need to make sure you're protecting the population. And if you're not doing something right, just like me or anybody else, if you're in the oral cavity and you can cause harm to somebody and you're not doing it accurately, you need remediation. And I'm a firm believer of that. Many states have adopted this because of problems, but so far Florida hasn't done that. So again, I can't answer that. Oh, well, everything's politics. But again, I can't understand the reason for it. I really don't. Maybe, I don't know. So anyway, so these are the things that have changed since I've been on the board. So in 2012, we reversed the, so after you place anesthetic or after you administer anesthesia, if there's an adverse incident, this has to be reported to the board within 48 hours by the hygienist and the supervising dentist. That's under 466014, and it's in Chapter 14. I apologize to all of you because some stuff is all bedded everywhere and it's not brought forward into the other chapters. So this is a problem. So I'm going to try to bring some of this all forward so you'll see that. Now, what an adverse incident means is when a patient sought medical care. It doesn't mean a patient goes, oh, that still hurts. It does not mean that. The patient had to have gone to a physician or a hospital to seek medical care for that procedure. That's what an adverse incident actually means. Then 2013, may administer LA to a patient under nitrous oxide as long as the dentist turns it on. We went through that. And for anxiolytics for life function, that also needs to be added to 1606 because it's in Chapter 14 under the sedation chapter. So I've got to bring that forward. And then in 2015, dentist and dental hygienist may get up to 3 hours for practice management coursework. Remember before that you couldn't get any CEs if you went to a consulting thing? So now you can. 2017 was my favorite year in the whole wide world. Dental exams while working. Okay, so this one is very, very interesting. How many of us truly believe that you have to have a dentist exam in 13 months, or now it's 24 months, before you can do a procedure again? In the office, right? There's a 13-month rule, or everybody calls it a law, but there's a 13-month law. I can't see, like if you go through your schedule in the morning and you go, oh, doc's not here today. Patient hasn't had an exam in 18 months. I can't see that patient. So we all believe that it was 13. Miss Angie Sassine, who resides in your hometown here, wanted to change that to 24 months. And it passed, so it got changed to 24 months.
Good for Angie.
Yes, it was good. So she got that changed to 24 months because she wanted it to mimic when the doctor writes a prescription for the nursing homes. She wanted it to mimic that. But the interesting thing is, it's only if you're working under general supervision. There is no laws or rules on exams. It's dictated by the standards of care in your dentist. So if you're working under general supervision, was 13, now 24, that means you better have an exam. But how many of us work for 2 years under general supervision? We don't. So really, that's not applicable to any of us. And none of us knew it. I didn't know it either. I truly believed all my life. I told my doctors, can't see that patient. You need to examine. It's only while working under general supervision. And it was actually put in there when general supervision came about. When we had prophylaxis moved to general supervision, this was put in there to make sure that a patient did get an exam at some point. That doctors weren't just, pretending like they had a dental practice, but they had more a hygiene practice and they were out on the golf course all day while you were doing prophies. So it was a fail-safe to protect the public. The same thing that in the health access setting, it says they must have an exam in 13 months. That is a law. That doesn't apply here. That's completely different. So if you're working unsupervised in a Head Start center, you have to have that exam in 13 months. And that's to protect that child, so that child doesn't go forever without a dental exam. It creates a little bit of a barrier, but it was designed to actually protect the child. So this was put in place to protect the patient in case the dentist didn't feel like ever being in his office. Interesting, huh? All of us, and I did too, until Angie brought this up, and then I looked at it 1,000 times, and I'm like, but that only applies if you're working under general supervision. And it's one of the hardest things for me to get everybody to understand. So
Understand that.
okay, that's why I said it's the hardest thing.
What's the standard of care then for an examination?
That's up to your...
13 months?
No, the standard of care is developed by the ADA and by your dentist. That's the standard of care.
Oh.
So if your dentist chooses not to examine a patient for 6 years, is that in standard of care? No. So, but if your patient is at high risk for caries and needs bite wings every 6 months and an exam every 6 months, that's the standard of care for that patient because that patient's at high risk. Okay. So you go by the guidelines of ADA, and the guidelines of your office. Your doctor has a right to implement his own standard of care. I've worked in offices where they believed it was 13 months, so they go, I'm good with 1 year, unless you find something, Kathy. Other doctors go, I want to examine every 6 months. I'm in a geriatric, I got peds, I got this, I want to examine every 6 months. They have that right to do that. They also have the right to say, you know what, you're with a patient who has no medical problems, no caries, no perio, you're good. Unless you find something, I don't really need to come in today because I'm doing surgery. They have that right too, but they have to justify why they chose not to come in for the exam if something happens. It's just like radiographs. Radiographs are not standard of care every year. That's not a standard of care every single year. It depends on the risk assessment and the factor of the patient. So if your patient has no carious lesions, has good control, home care control, why would you take radiographs? Why would you take bite wings every year? It's not a standard of care. So they're developed by the ADA too, radiographic standards.
Is ADHA's standard of care recognized?
No.
Okay.
Because we don't develop standard of cares. We're supervised.
Okay.
Yeah. So it's basically on the supervising dentist in the organization.
I have a question then.
Yes.
So I actually don't have a license for Florida.
Oh my God, you're on licensed activity.
No? Activity for a CE, yeah. But I'm licensed in 2 other states.
Uh-huh.
And in those other states, the laws are that they have to have an examination 1 time per year.
It's not a law in our state.
Okay.
And we all thought it was a law too,
Okay.
so I don't know where it's written in yours, so you might want to look at it again. We all thought it was a law.
And so when you're saying that
Yeah.
about the ADA, I know that...
Every state has
Okay.
different ways of writing their laws and stuff. Some states might want a laundry list it all out.
Yeah.
I don't know.
Okay.
Ours just doesn't. You know, we're all different. Yeah. So it is very, very interesting. It's everything. It's everything interpretation. Okay, so then, so kudos to Angie for that. She changed it, and actually she allowed me to understand it a little bit better because she brought it up. RDHs were added to probable cause panel. I cannot tell you how many times there's been an issue that was hygiene related that comes in front of the full board, went through probable cause, and I hate to say this, but most dentists don't really understand the full aspects of hygiene. So I begged and asked, please, I put that through as a proposal, went through the Council on Dental Hygiene, that if there was something that had to do with a dental radiographer or a dental hygienist, that a dental hygienist be asked to sit on probable cause. If you couldn't find one, that's fine, but you have to have that opportunity of a board member or a past board member to sit on that probable cause. Because it's only fair to the profession that you have peer-to-peer. So, and I've got to say, and I'm just going to throw kudos out, my favorite board member in the whole wide world, not because I didn't like all the others, and I like them all, Dr. Joe Thomas. He championed everything because he believed in it. And he said, you guys are very well educated. He goes, this is ridiculous that you're not involved. So he was the one who championed so much of this to help us because nobody could prove that it was unsafe for the public. You have to remember why you're there. You're not there self-serving. You're there to protect the public only. Okay, and then scaling and root planing went to general supervision. Everybody remembers that? Anybody at those meetings? Oh yeah, those were very interesting. I had to sit, well, okay, what happens when somebody puts a rule through, like say we write a rule. We write a rule, the board accepts the rule, so whatever committee develops the rule, bring it to the full board, the board accepts the rule. Then it's got to go through what we call the Joint Appropriations Committee, which is another administrative part of the Department of Health. We call them JAPC. JAPC looks at that because it wants to make sure that you can do that rule. Okay, so it wants to make sure that that rule can be, that it's not stricter than the law and that you have that power to do that rule. So it's an oversight committee, which is really great. So when, and then anybody has a right to challenge a rule and do a rules workshop. So when we put through scaling and root planing to general supervision, I believe it was the Florida Dental Association, the Florida Academy of General, the Florida Academy of Perio, the Florida Academy of Pedo, the Florida Academy of Maxillofacial Surgeons. Every single one signed letters to do a rules workshop challenge. They wanted to not accept that rule. They weren't happy with it. Which I'm going to be honest, that was my biggest thing I wanted to do when I got on the board, because every time I would look through my schedule in the morning, I'm a laws and rules person. I would look through my schedule in the morning, aside from misunderstanding the 13-month thing, I would have perio maintenance. And I would say, I can't do this, because perio maintenance includes scaling and root planing. so I couldn't do it. And how do I reschedule a person for 3 months? I got no room in my visit, no room. And the front team didn't know that, so they scheduled them. They didn't know the doctor was going to be sick or go to a meeting or do this, so they scheduled them. And especially when you're in a single dental practice, it's really hard. So I would have to reschedule those patients. And I thought that was absolutely ridiculous. How was that helping the public? When now they can't get their perio maintenance that they need to control their disease. Who's helping the public then? Again, it's like what I said to Morgan. Who's helping the people that get nothing, you know? So I thought everybody would be happy with that. So I sat for 2 hours and listened to how incompetent we are, how many people bleed out, possible emergencies because dentists had seen it. Oh yeah, no, there were maxillofacial surgeons saying I see it in the hospital all the time, the damage that you guys do. I did a lot of research. I researched back 15 years to see if there were any Practice Act scope of practice violations against a dental hygienist, and there were none. Whitening was the only one, okay, that had been. So I researched very, very well. I made sure, we had 4 or 5 council on dental hygiene. I made sure that I brought in somebody who was a commissioner on CODA for dental hygiene to explain the CODA standards to everybody so they knew how well we were trained and licensed, our education. I wanted everybody to really understand everything before people made this emotional decision, because it was an emotional decision that they wanted not to do that. So we had that 2-hour, I actually had a periodontist who got very, very mad at me because I had said that we don't teach scaling and root planing anymore, so he got mad at me, and I quoted a dental hygiene book. So he wrote a letter to the Surgeon General and the governor saying, how dare a dental hygienist quote me, tell me and quote a dental hygiene book. It was such emotion involved around this. It was crazy. I never in my life thought that would happen. So what the good news that happened in that room is nobody had any proof that it could harm somebody. Nobody could prove that. And the surgeon who had said, I see it in the emergency room over and over again, I said to the surgeon, well, there is part of the Practice Act that says that you have to report that. Could you share with me why that wasn't reported? You have to be like that. You have to be very logical, very matter of fact, and just support why, you know, whatever somebody says, why that might not have been, or maybe it could have been from another reason, you know. I mean, I don't know anybody who's ever bled out in my chair. I mean, never. And if they did, what is the doctor going to do any different than I'm going to do? Except maybe put viscostat in the sulcus. But 911, right? That's what we do. So the good news is it got passed. Antimicrobials went along with it because a lot of times when you're doing perio maintenance, it might be on your treatment plan. Or you might be treatment plan to do an isolated scaling and root planing that the patient doesn't need local anesthesia, and now you can do it and place your antimicrobials there. But you still can't anesthetize a patient under general. So if you're doing a patient that needs to be anesthetized, it has to be under direct supervision, okay? This is only for the patients that don't need anesthetic. And then we added silver diamine fluoride to our scope as well, and we didn't really need to add that. What happened is Dr. Scott Tomar from the University of Florida, who runs a dental hygiene-based program out of their, one of their public health facilities over there, he wanted the hygienist to use SDF. And the hygienist said, I don't see it written in my Practice Act. I can't do it. So he wrote a letter to the board and asked, that came back to the Council on Dental Hygiene, because anything hygiene related has to go back to the council. I did my research on that and actually found in the writing of our law and our rules that any fluoride that's approved by the ADA or the Food and Drug Administration, we can do. SDF was the same thing, just because it's called something different. But I actually wanted it added because I wanted people to know. I didn't want to have another hygienist at a health center say I can't do that because it's not written. Because that's what we hear. If it's not written, you can't do it. And but it could be layered into something else, unfortunately. Like SDF actually falls under fluoride varnish because it's a fluoride. Just because it is silver, and it's still a fluoride. Still a fluoride. So that, and then we amended the hygiene prescription just for clarity because it was paper and you had to have another copy and this, so electronic. So we did that. So in 2018, we added advanced oral cancer screenings, right? This was another area that was interesting, but I wasn't, you pick your battles, okay? You pick your battles. So in this, in our chapter, our rules of our remediable tasks, under general supervision, it says that we are allowed to use all implements required to do an oral assessment. That's an implement to do an oral assessment. I actually didn't have to ask for that either. But I wanted it in there because it was the Board of Dentistry many years ago said it's not a remediable task for a hygienist. So I wanted to make sure it was in. They wanted it under direct supervision. I settled with indirect, and they settled with it. Sometimes you just got to give and take. It's okay. As long as we can do it for our patients. That's what's important to me. We actually can own our own equipment now. Before we weren't allowed to. We could own equipment as long as the dentist said they liked it, and it was okay. But if we're working in a health access setting, doing sealants and everything else unsupervised, we have to own our equipment. So again, that shows you where a rule was old and needed to be changed because it didn't align with the statute. Let's see what else. We added without supervision references. This is just for public health stuff. We wanted to make sure that it was referenced that we could do oral screenings unsupervised and stuff. We wanted to bring forward it into Chapter 16. And then we removed topical anesthetic, which is applied by aerosols or jet. We now can do that. We can inject and we can jet too. So we're good. All right, so the restorative expanded functions dental assistant and dental hygienist. Everybody knows that passed, right? We can now have what a lot of states will call an FDA. We can now do that. So these are the requirements. Okay, so within 24 months, this is for the hygienist, within 24 months, you have to documentation of 24 hours of experience. That includes your dental hygiene program, all right? Because that's 2,400 hours of experience. You have to do 85 clock hours at a dental accredited school or a dental hygiene accredited school. 5 are didactic, preclinical, 55 are sim lab, 25 on live patients, and then you do a final written exam on a live patient. You get a little certification, just like if it expanded functions, and then you have to place that wherever. You are allowed to pack and carve amalgams and composites, okay, with a slow speed or hand instruments, no high speeds. So that means, and this really will help those public health settings like the federally qualified health centers when they only have 3 dentists, that the hygienist or the DA can come, they can go and prep and they can come behind them and pack and carve. This is under direct supervision though. For the assistants, they could either be a dental assistant on the job trained with an expanded function, maybe in radiography. They could graduate from CODA programs, they could be CDCAs, or they could be expanded function with multiples, okay? They could be anything and go in. So they have to also, within 24 months, document that 2,400 clinical hours of experience as a dental hygiene educator in a CODA program. They could use that. They have to be CPR certified, because remember, dental assistants don't unless they work on sedation patients. They have to have 105 clock hours. 10 preclinical, 70 lab, 25 live. They take the same test, but they are not licensed and tracked. That's the difference. So, under direct supervision, after the doctor preps, they pack and carve amalgam composites, no high speeds. They can do the class 1, 2, 3, 4s, and 5s. I had a really hard time.
But they're not regulated.
Nope, no tracking system.
That doesn't make sense.
That's what your board, I didn't vote for that. There was 3 of us that didn't, the rest voted for it. And it's the majority rules. That's what a vote does. So I worked very hard to try not to get the same hours, because most of the board members thought we should have the same hours too, that an expanded function dental assistant has. So I had to justify, and quite a few people from FADE came in, again went through our credit. I've already had dental materials, I've already had instrumentation, I've already had this, I've already had that. Why should I repeat it? So we had one board member who was really, really good. He said, okay, I'm going to give an example to everybody. Because sometimes you have to just logically spell things out because people are driven by emotion sometimes. So he said, I've got a dental assistant, expanded functions. I've got a dental hygienist who went through a program, licensed, everything. I'm going to pay for both of them to become FDAs. They're going to come back to me, and I'm going to say, what did you do yesterday? What did you learn? And my dental assistant's going to tell me, I learned fulcrum and how to position and use an instrument. And my dental hygienist is going to say the same thing. I'm going to be pretty pissed that I had to pay for her to learn that again, or him that again. So he said, logically, why on earth would you require that? So the board wavered back and forth a little bit, and we finally got it down to 85 hours for us. Okay, but again, licensed and tracked. There is no school presently that has it, though. I think UF is looking at it. But this was an emergency that had to be passed through last year. So there was some reason Dr. Tahara, who was the board chair, had said to me, Council of Dental Hygiene, we need you to get this done because it has to happen this year. Yes?
So if you have it from another state,
If you could say that you satisfy, it's just like local anesthetic, okay? That was a big question when LA passed. If I'm certified in another state, can I be certified in Florida? If you meet the benchmarks of all of that, then you could be.
So like if I,
A lot of states call it FDUP. We don't even know what we're calling it. Expanded function, dental, restorative, expanded function, dental, auxiliary. I don't know why they call it an FDUP. We don't call it an FDUP. We're going to call it restorative expanded function.
Since this is passed already,
Wait 1 second.
since this is passed already, and I was speaking with Teresa, she has this from her other.
But she has to have all of that.
But if she has all of that, can she now apply to the board?
She might be able to apply for certification, yes. But because this is so new, just like when anesthetic happened, there's only one state that has more hours than we do for local anesthesia, and that's Louisiana. So a lot of people were applying, and they only had 35 hours. They could not get local anesthesia in our state because ours specifically wrote out all of these. Now, this is good. This is important. You had to have 5 a preclinical, you had to have 5 didactic sim, 25 live patient, you had to pass that test. I mean, so you have to hit all those benchmarks.
Yeah,
How many hours did you do?
It was on our board. I mean, we had, our dental hygiene board for Washington State and Minnesota.
But did you have all of those practicums?
Yeah, because it was a program.
Okay, so it was in your program. It was in your program. So you would have to have your instructor pull out that you've completed all of those, then go in, and I guarantee it will go in front of the board, and we'd have to make a decision on that, because those decisions aren't made before they make these decisions. So, yes?
Could you just kind of clarify that first bullet point under dental assisting education requirements?
Within 24 months, documentation of 2,400 clinical.
Providing hygiene education?
Right, it would be clinical experience or as a dental hygiene educator in a CODA program. So what that meant is that, okay, so there's so many different pathways. If you're just a dental assistant, right, and you're going through, and they want to make sure that you worked on a patient for 2,400 hours. But say you were a dental assistant that worked in a dental hygiene education program, or a dental assisting program is on there too, and I left that one out. You've already done a lot of stuff in academia, right? So they will look at that in conjunction. You could have maybe 1,200 in the clinical and then 1,200 there. They will look at those and lump them together. The reason that's there is they wanted to make sure that somebody who hadn't practiced in 6 years or touched a mouth in 6 years went into the program. They wanted to see that within 2 years, you could justify that you had that much training or you had patient contact experience. It could have been just retraction, because that could have been what the DAs did, but at least they had 2,400 hours of a retraction. Help?
Yes, and then if it's not done within 24 months, that's when the other pathway is.
Right, well, the only way that a dental assistant they have to have had, even for hygiene, if I didn't do clinical hygiene in the last 7 years, I could not enter that program. I have to have had, right, I have to have had 2,400 hours of clinical experience, whether it be in an educational institute or a clinical patient, within 2 years. And that was to protect the public, so like I said, somebody who hadn't touched a mouth, because they don't like people to, you're rusty or whatever. So that was.
Only new clinicians really are going.
No, or how long have you been practicing? Oh, no, I'm not even going to ask you that. That's right. You're practicing illegally. So say you've been practicing 20 years, you're good to go. But if she's been practicing the last 5 years, she hasn't practiced at all, she can't get in. So within 2 years, you have to be able to prove that. And I wanted to make sure that the students coming out of dental hygiene school, that was good too. Because guess what? They see a lot of patients in those 2 years. So I didn't want them to have to go out for another 2 years before they could go in. So they could actually go right into one of these programs. So, I was thinking at Palm Beach State College, they have a whole entire summer where they close the clinic. 6 weeks they closed. They could have a program in there for that 6 weeks, roll their students right into that while they're waiting for their licensure and everything, and oh my gosh. They now come out with the restorative, they come out with local anesthesia, and that's the huge pathway to dental therapy. I don't know if any of you knew that. To get into the Colleen Brickell's course in Minnesota, dental therapy, and do 16 months, you have to have this and LA. It's a huge pathway to dental therapy. What? No school's done it yet. Right, this just passed about 4 months ago. So I know UF's looking at it, and I know Valencia's looking at it. I don't know if they're looking at it.
I think they're trying to concentrate on dental therapy.
Yeah, they're going to do dental therapy. I know Miami-Dade's doing a dental therapy program when it passes. Notice how I say when. Okay, so this is what we're proposing. Being that we have money left over at the end of the biennium, why should we have to be paying more licensure fees? So we dropped licensure fees. It hasn't happened yet, but I'm hoping it gets put in by February, because I'm presenting this tomorrow. Unfortunately, my mom was very ill this whole entire year, so I didn't get to the last board meeting because my mother was ill. So I'm dropping it down to 75. Gosh, I probably should have dropped it down a lot more. RDH may only use a laser device for assessments. So if anybody knows anything about when we tried to push through that hygienists use a laser, it was niched. It wasn't happening because in Chapter 16001, it states in there, because that's the definition of remedial tasks and all that kind of stuff, it states in there a license is not a remediable task for a dental assistant or a dental hygienist. And my response to everybody who says that is like, you're 100% sure, correct, it's not a remediable task. It's a device, it's not a task. The task is scaling and root planing, the task is whitening, the task is desensitization, curettage, those are the tasks. That's a device. You don't regulate my ultrasonic. You don't regulate my piezo, my handy, my air polishers, but nobody paid attention to me. So, it's logic. I came with logic, they went with emotion. So.
And that's only for a diagnodent?
Correct. Okay, or for this. I can't use this on a patient either, because it's a laser device. Okay.
Because you couldn't use it like that, there's nothing in there about a dial.
Anything that you're using, no, you can't use a laser for bacterial cytoreduction. No, only for an assessment. Only for an assessment. So again, lasers are not remediable tasks. They're devices. So, yes, but now I know after, at some point there will be, maybe it'll come back up. Not today, it won't. So, but I am going to, after this, and it goes through the whole joint appropriations and gets written, got to remember it takes about 2.5, 3 months once the board accepts something. I will be able to use my laser pointer the next time my patient's with me.
What are you using a laser to assess?
What?
What are you using a laser to assess?
Oh, diagnodent is a laser. There's a device called a diagnodent, which is actually detects demineralization. Oh, it's fabulous. I used it for years until I found out I wasn't allowed to use it. So.
It's really great though.
Oh, it's fabulous.
If you're paying attention to the
Yes.
numbers, then you can tell if it's penetrated beyond a certain
The
point.
dentin, yeah, if you remineralize versus, because now we got Canberra, so you want to do a lot of remineralization. We don't just watch them wait nowadays. We do something. So we remineralize or we cavitate. So it gives you the numeric number. So anything under 25 is you're fine to remineralize that if it goes a little higher. And I've actually seen videos where they've gone in and prepped because of the way the readings were, and they actually could carve out less of that tooth because they found out where that decay was. Amazing. Or they couldn't see the decay on a radiograph or visually, and when they went in, the diagnodent went like, it does this thing and goes that and gives you a number, and they were like, they went in and it was bam everywhere. Bam. Yes. So it's really a great assessment tool, and it's not going to hurt anybody if we use it. So, and then I wanted to find out if we could actually move our bleaching from direct supervision to general supervision, because in reality, every dental assistant's doing it, and they're not supposed to. So, I'm proposing that we move it, because I don't think we're really going to hurt anybody, right? We can scale and root plane under general. We can apply bleach under general. And then this was always funny for me. we could only take impressions for opposing models, stents, fluoride trays, passive appliances, bleaching and study casts on indirect supervision, but we can adjust them under general. You can't take it, but you can adjust the device later, or the appliance under general. So I think it's just oversight, like not looking at them. You got to look at these things and figure, they don't make any sense, you know? And you got to change them. And then an update of the sterilization to mirror OSHA and CDCA, except for sterilization of slow speeds on dental hygiene instruments. That did not go through, okay? And the reason that did not go through is because it's not a mandate, it's a guideline. And there was one study that possibly said there could be some bloodborne. The other thing is when you impose a rule as Board of Dentistry members, when you put in a rule, remember we have our oversight committee. If we impose a rule that is going to cost the profession of dentistry, which is dentist, a lot of money, over $200,000 in the state of Florida, we would have to put in a whole work plan of that, and that would have to go through this administration and that and that and that, and the likelihood they accept it is no, because of one study. You'd have to have enough to support that. That doesn't mean the dentist slow speeds don't. So a slow speed that touches the top of the slow speed, if it touches the oral cavity, like a slow speed of a dentist, that has to be sterilized. The metal prophy angles, they have to be sterilized. The motors do not have to be sterilized after every patient. No, this did pass. Well, this hasn't been written in yet. It's close. Right, but so the reality is they wanted to add the slow speeds to it, but the Board of Dentistry said no, because there would be too much of a regulatory cost throughout the state, and it would never get through. Yes?
I thought that one was voted on in the August meeting.
It was voted on in the August meeting, but because of the regulatory cost of the slow speeds were taken out. Right. Yes.
Do you know when?
It hasn't been written in yet.
Okay.
It takes, again, it should be soon, very, very soon. So again, it's got to go through, it's got to be posted. You have to actually post it for 21 days in case somebody wants to have a challenge on it. Then when it goes through the joint appropriations, if they don't have a comment, like tomorrow we have a lot of anesthesia rules that are coming back, even though they were voted on because the joint appropriations committee had questions. If you didn't capitalize something, it's coming back. And you're like, then it can't be posted as a final rule until it is. So it can be clogged up in the system with bureaucracy for a while. So hopefully that'll happen very shortly. So that was all proposed for changes for 2019 and 2020. That's why I put 19 and 20, because this could happen before the end of the year, but these will not. These will take longer.
The slow speeds aren't sterilized right now, is that?
Correct. It's not mandated in our rules that we sterilize
They could be just disinfected?
dental hygiene slow speeds. Correct. Now, should they be? Probably. But because the problem is it's not a mandate, it's a guideline, okay? And we have a right to accept it or not. It's just like those black boxes. We're not EPA mandated state. We are not an EPA mandated state. Each state accepts whether they want those guidelines or not. So every state, and that goes through the Environment Protection Department. So, and I had to look that up because somebody asked me if I could look that up. And actually, I have to inquire more about that because it looks like it was accepted in June of 2018 or 2019, forgive my brain, and it looks like it was retracted in August of 2018 or 2019. The disposal of the pharmaceutical drugs, anything left over like your fluoride varnish, your anesthetic, should have gone in a black box. There are 5 states that are EPA mandated, so whatever the EPA wants, they have to do it. The other states can vote on that. So that's like, it's interesting because it says there that it was adopted in June, and then it just says there in August it was retracted completely. That rule was retracted. And so it's all confusing. So additional requirements, let's see, what's rule conflicts? Oh, this is a tough one. This is going to be coming up soon. In chapter 16, which is our chapter, it states that we can monitor nitrous oxide under indirect supervision, right? In the anesthesia chapter, which probably nobody looked at for a lot of years, it says that we have to do it under direct supervision. So we're in conflict. So that's going to be brought up tomorrow. Also, this is something I didn't know, but I did take this course because it was in my education years of teaching, that we have to satisfactorily complete no less than a 2-day course of training as described in the American Dental Association's guidelines for teaching and comprehensive control of pain and management in dentistry or its equivalent. If you monitor nitrous oxide, you should have had that course. That's written in chapter 14. It's not in our chapter. So was that for sedation or was that actually for nitrous too? So the way it is, it's hard to understand if it was for, because it's lumped together with, conscious sedation, general anesthesia. It's lumped together with all of it. So I'm like, was it for that or was it actually for nitrous? Because that to me is kind of crazy to take that 2-day course, because I took that course only because it was offered at the school and they were like, oh, can our hygiene students go? It was all over my head. So, and then of course they have to have the cardiopulmonary resuscitation and defibrillator. And any dental assistant or any dentist that's doing sedation certified has to have 2 assistants in the room. And they may not leave that patient until the patient is completely conscious. They have to stay in that room at all times. Not nitrous, but for the sedation. So this actually was changed in 2009. So there's something in one of the other chapters that states that we have to do the least regulatory process to protect a patient. So this has been going on for how long? 10 years? It's least regulatory than this one. So why would you want to change it if that's the least regulatory and there's not been any problems? And I don't know how you would directly supervise my monitoring. I'm confused by that. I'm going to ask them to explain that to me tomorrow. Do you come in and say, are you looking at that okay, Kath? It's okay? I mean, how do you monitor that? How do you directly come in and check if I'm monitoring? I mean, again, logic. So, anyway, human trafficking, you all know about it. Have you taken your course? Are you going to go to the next one?
January.
Perfect. You have to have an 11 by 12 sign posted with this in there, in your operatory. Not in your operatory, but in the office, at some place in the office. And this is by 2021, you have to have it. That's the state of Florida. I don't know if it's a federal. I know that it's all of health professionals. But it's one time in licensure. That means no students. You have to be licensed to take it. And you never have to do it again. And except for massage therapists, they have to take it every renewal. And then laws on radiographs. There are no laws on radiographs, everybody. So if your front team tells everybody there's a law, can't come in unless take radiographs because it's a law, they're wrong. Recare, told you that. Did that one, covered that one. Other team members can treatment plan. No, they can't. Dental assistants cannot use a scaler to remove plaque. Okay. DAs can only use toothbrush or rubber cups. And they need CPR. So I think I've covered all of these. All right. I think I did it. And how to protect yourself. You can see Miss Linda in the back. She'll help you with that one. But know your delegable duties and your tasks. If your docs don't know it, download that book and put it in your operatory. I always had one in my operatory. Go through it. Documentations to standard of care, provide informed consent, provide alternate treatment. There is a law that says you must provide alternate treatment. Example, implant or a bridge. You can't just say you need an implant. Sorry, that's all you need. You have to be able to say you could also have a bridge. Or you could have a removable. Or you could have, so you have to do that. Only dentist does the diagnosis and authorizes the procedure. You all know that, right? Does that work? Yeah? Okay. Know your limitations. Refer when needed. Do no harm. Ignorance of law is not an excuse. Review laws and rules with your team on a quarterly meeting. So, and that's us. All right? That is us. So, and they all do a really good job, and we're not paid for it. I'm sorry, the governor does give me $45 after taxes. I get $45, and we're not, and it's a lot of work. It's a lot of work. It's hours and hours of work. But if you love it, you love it, and it's not for everybody, but it's good. Thank you. Any questions?
Do you want to say anything about dental therapy?
I kind of did in the beginning. Does anybody have any questions on dental therapy?
Can you tell them all about tomorrow's Board of Dentistry and how they can get CE credit?
Oh, absolutely.
How interesting it is.
It is interesting. Tomorrow will be interesting. You can come to the Board of Dentistry meeting. It's over at the Omni Hotel. We start at 7:30, unfortunately. And you can get CE credits for it.
You just gotta sit and listen to it.
It really is interesting. It really is. It's very, and we have, our board attorney's so good with explaining things, so it's really very interesting. A lot of times the students come too, so it's really cool when you see the students. Yes, question?
I just moved to Florida from Vermont, and why, and maybe this is a question that you guys have heard a million times, but why does Florida not have reciprocity?
Okay. Florida now does have, okay, let me explain. Florida accepts the ADEX exam. So that is our form of reciprocity. So if you took the ADEX exam, you can come to our state and just take laws and rules. So you have to take, did you take ADEX?
No, I mean, it's not a Northeast.
Right.
And
It is now. It's actually in almost, it's probably in, God, 30, maybe 40, 46 states now recognize and administer ADEX. Within 2012. We started accepting it within 2012. So I couldn't go to another state, as I took Florida.
Do you mind going back to slides where the minutes was? I just couldn't read it.
Here's my clicker. Thanks.
Thank you.
No problem. Figure out which way my thing goes. It's a new one and I hate it. Okay. You're very welcome. Yes. Shh, 1 second. Somebody's asking me a question.
Anesthesia on doctors' patients.
There's no regulation on that. You can anesthetize as many people as whoever you want, whenever you want, how you want, as long as your doctor supervises it and authorizes it. That was another thing. They didn't want hygienists anesthetizing the dentist patients. Why not? Yeah. Tell me how that's going to hurt somebody from my patient to a doctor's patient. Really? So. Yes.
Is there anything written about like the frequency of periodontal charting, or is that more standard?
That's standard from the American Academy of Perio.
Okay.
Yeah, a board of dentistry doesn't deal with that. But now if somebody comes in front of the board and there's never been a perio chart, there's a problem. Right, that is not considered standard of care. Right, so yeah. And PSRs are not standard of care any longer. They were when I was in school, but not anymore. That's from the World Health Organization. That's a screening tool. So.
Any other questions for her? Phil, please fill out your evaluation forms and let's send them this way.
Thank you.